Optimizing CRT in Unresectable Stage 3 NSCLC. The views and opinions expressed in this video are those of the individual oncology specialists and do not represent the views or opinions of AstraZeneca. This video contains anecdotal information gathered from a discussion with oncology specialists based on their opinions and experiences. Recommendations are general and may vary with patients. At the time of this filming, the healthcare professionals featured were in the roles and at the institutions indicated. The topics discussed in this video include the multidisciplinary team, determining radiation therapy, and preparing patients for CRT.
Hello, I'm Janakiraman Subramanian. I'm a medical oncologist. In this video, we'll be talking about optimizing the use of chemoradiotherapy in unresectable stage 3 non-small cell lung cancer. To help with that discussion, I'm joined by two thoracic oncology experts.
I'm Stephen Sean. I'm a radiation oncologist.
Hi, and I'm Megan Roy. I'm an oncology nurse navigator.
Here is the first topic, the multidisciplinary team.
Once the multidisciplinary team has determined that the patient has been diagnosed and staged appropriately and meets the eligibility criteria for concurrent chemoradiation, it is the role of the medical oncologist and the radiation oncologist to develop the comprehensive plan. A multidisciplinary setting is key to have those discussions rather than, as a medical oncologist, me independently making the decision, having the input from you as a radiation oncologist, the nurse navigator who can give the background on this patient can really inform us on, choosing the right treatment option for these patients.
Stage 3 disease is pretty heterogeneous, and each of the specialists on the team are critical for making the proper assessments that ensure appropriate treatment decisions.
Members of the MDT include medical oncologists, radiation oncologists, pulmonologists, pathologists, thoracic surgeons, and oncology nurses.
The nurse navigators, I think, are really at the center of a multidisciplinary team. They are the sort of the heart and the brain because they connect between all the other team members and communicate between them as well as with the patients. And so they are, absolutely indispensable, I think, for the MDT. Now, Megan, as a nurse navigator, what is your role when these patients are newly diagnosed with non-small cell lung cancer, particularly stage 3 unresectable disease?
So nurse navigation will help bring the patient's point of view to that tumor board since they can't be there and let you know if they're going to have transportation issues or are we going to have any other disparities of care and be able to discuss what resources are going to be needed to help get that patient through that treatment.
Our next topic is determining radiation therapy.
As a medical oncologist, in some ways, the actual treatment planning is somewhat straightforward for me, particularly when giving it concurrent with the radiation. And that is primarily a platinum-based chemotherapy regimen is what we are choosing. But at the same time, we have to be careful in the sense whether the patient can tolerate that particular chemotherapy. And there are choices of chemotherapy regimens that we have to choose from, whether cisplatin or carboplatin-based regimens would be more appropriate is a decision that we have to make. Similarly, depending on the tumor histology, we may have to choose different types of chemotherapy treatment for those patients. Now, from the radiation standpoint, how do you determine a patient is eligible for treatment?
So I think when we look at the history of radiation for locally advanced non-small cell lung cancer, we used to think that only young patients with good performance status were candidates for chemoradiation. But with decades of research dating back to even the late 1990s, what we've seen is that even elderly patients with somewhat marginal performance status also benefit from chemoradiation. We should remember that the chemoradiation trials that are done today allow patients usually with a performance status up to 2, and that's using the ECOG or ZUPROD performance status system. It's also important to remember exactly what a performance status of 2 means. This isn't just eyeballing a patient and kind of making a subjective judgment. It means someone able to care for oneself and up for more than 50% of waking hours. And so, again, I really urge people out there, don't discriminate on the basis of something like age or disability. Really look at the definitions and be as objective as you can about what is the true performance status of this patient.
Now, Stephen, how do you prepare your patients, particularly with radiation treatment that they have to be coming in every day and some of the later toxicities that you deal with?
When planning radiation therapy, whether it's the National Comprehensive Cancer Network or the NCCN guidelines, the American Society of Radiation Oncology guidelines, American Radium Society appropriate use guidelines, whatever nationally validated guidelines you would be using, these are very important guidelines that serve as foundations to deliver safe and effective radiation plans for what we now recognize as often curable patients. I am part of the process of planning radiation as a radiation oncologist. So I'm kind of the quarterback of the radiation planning team. This is a multi-step process that involves a number of different elements, including the radiation therapists, the radiation physicists, radiation nurses. And we develop plans based upon imaging, contouring both tumor and normal structures, and prescribing appropriate radiation doses for a specific patient. Most patients these days are treated with advanced radiation techniques, specifically intensity modulated radiotherapy, also known as IMRT. IMRT very carefully sculpts and molds to convex and concave shapes, whereas 3D conformal therapy, which is directed in straight lines at tumors, has less of an ability to shape to the often abnormal shapes of tumors. And this allows us with IMRT to treat tumors better, but also to spare normal tissues like the heart and the lungs from excess doses of radiation. I almost exclusively use intensity modulated radiotherapy for locally advanced lung cancer because of increasing evidence of the benefits of using intensity modulated radiotherapy that reduces likelihood of pneumonitis or inflammation of the lungs. It also reduces cardiac exposure. And so in the age of chemoradiation followed by appropriate therapies, techniques like IMRT are of heightened importance, in my opinion.
Our final topic is preparing patients for CRT.
Megan, how do you help prepare these patients for their upcoming concurrent chemoradiation treatment?
I educate them about the type of lung cancer. I make sure they understand all their different treatment options. I let them know what to expect and how long and what is going to be required of them to make it through the whole treatment, to keep them prepared as best as possible. I'm constantly reinforcing the information they're giving, and I want to make sure they understand each step of the process. Once the patient agrees to getting chemoradiation, there's a lot of different steps included. They have to get through their simulation, and then they have to wait for that planning session to be done. So they're calling me, when am I going to hear? When am I going to hear? So it's constantly re-educating and keeping in touch with the schedulers and making sure everything aligns right. And making sure they have my phone number, because sometimes, depending on what institution you are in, it might be the only person that's answering live and not getting a voicemail. So it's really important for us to develop that relationship so they know they can call at any time. But another thing that's really hard for patients is, getting to the institution every day. It's a long process. It's 6 to 7 weeks of daily radiation and once a week chemo most of the time. So it's a lot for a patient who can't communicate or needs to get a ride or lives 2 hours away and they might need lodging. So getting a social worker involved early is really an important part so they can help start setting up those resources that are going to be needed. Getting that nutritionist involved early and making sure that they know their calories and what they need to do to maintain their weight to get them through treatment is important also.
The radiation nurse, I agree, it is so important in helping me with the patient during and after treatment, including with the expected adverse events, particularly esophagitis that they might experience. But we also really rely on the nurse navigator to bridge the gaps in communication and help coordinate patients throughout this process. What I think is really important is to try to put oneself in the mindset of a patient with locally advanced lung cancer. This is probably the most stressful situation they have ever been in their entire lives. It is so important to explain things in simple ways.
In summary, in a Stage 3 NSCLC setting, effective multidisciplinary care can help ensure appropriate treatment decisions, which is particularly important given the heterogeneity of Stage 3 disease. It's also important to be objective about performance status and which patients will be able to tolerate CRT. IMRT may further optimize treatment and reduce toxicities. Nurse navigators can help guide patients to complete their full treatment journey.
In closing, you can see that there is a lot of planning and preparation needed by all of us, along with our patients as well as their caregivers, to ensure that we can start concurrent chemoradiotherapy and ensure that it is optimally delivered for our patients. Be sure to look for other videos in the series. Thanks for watching.
There are additional resources on azinearlylung.com that can help with patient management. These include the patient intake form, the MDT guide for optimizing CRT, and the nurse guide for week-by-week AE management during CRT.